Good afternoon, and thank you for joining us for today's webinar, Telemedicine Reimbursements and Billing. My name is Heather Bradley. I'll be your administrator for the day. First, a few housekeeping items. We will be taking questions. You can type them throughout the presentation. We'd ask that you only type them. We will not be answering any raised hands, and we will answer your questions at the end of the presentation. I'd like to turn over the webinar to Caitlin, who's our telemedicine project coordinator here at Adirondack Health Institute, who will introduce you to your presenters today.
Hello, everyone. I am very excited to have with us today Cynthia Gordon from Rochester Regional Health. She is their Director of Telemedicine. She's been a nurse for 38 years with extensive experience in patient care that includes critical care, ED, OR, PACU, and care management. About 9 years ago, she and Dr. Ralph Panino, the Chief of Surgery at Rochester Regional Health, initiated a telemedicine program for the healthcare system. And currently as director, their system has expanded to include services to skilled nursing facilities, primary care, and will continue to grow specialty consults for patients in both their urban and rural communities. Cindy has presented both locally and nationally, including at the American Telemedicine Association on Rochester Regional Health telemedicine programs. With Cindy is Diane from Compliance, and she is going to introduce herself.
Hello, my name is Diana Viscani. I'm the Compliance Coordinator for the Telemedicine Program here at Rochester Regional. I've been working with Cindy and Dr. Panino for the past 8 years, and we hope you enjoy the presentation.
Okay, this is Cindy talking, and one of the things I'll say right from the very beginning, if you're just new starting a telemedicine program, I would definitely suggest that you get to know your compliance person, because you always want to make sure that whatever you're doing in billing, that you're following the rules. I always said I don't look good in orange, so therefore I don't want to be doing something that I'd have to have somebody from legal come after me. So we're very fortunate right now. When I started this 8 years ago, there were many questions, many more questions than there currently are, because things have changed. But just to start off, I'm sure all of you are thinking, who and what services are currently reimbursable? I'd like us first to ponder that not always is what we're doing about reimbursement. As a quote that just recently came from SG2, leading adopters of virtual health view their programs as less about revenue and more about cost avoidance and closing gaps in care. And I think we have to think about that as we move forward into this whole accountable care, and we're moving out of fee-for-service. We are charged with providing care to our patients, and a lot of times we're providing, those patients are in areas that it's difficult for them to get to their specialist or even their primary care visit. I know a lot of you are from the rural space. In Rochester, we're obviously both rural and urban, and in the past, a lot of our programs have been focused on our rural population, but we have to remember that our patients that live in urban populations are also socio and economically challenged. Sometimes them getting to a doctor's appointment is as onerous as somebody that's living in a rural space. So we're being challenged now to make sure that every one of our patients get the care that they need at the time that they need to get the care. Yesterday, Rochester Regional Health was very fortunate to have a national leader in telemedicine, Dr. Jay Sanders, who is one of the leading founders of the American Telemedicine Association, as well as he's been using telemedicine since 1969. He spent the entire day with us at the healthcare system, and he challenged us to really start thinking about how we deliver care to our patients. And one of the things that he said to us, that as we move forward in healthcare, it's no longer about the patient going to where the doctor is. It's about the doctor going to where the patient is. So again, another challenge out there, and how are we going to do this with the technology that we currently have? So I can talk a little bit more about as we go into the end of the presentation. I will talk about that, but I want you to think about the technology that I'm sure every one of you right now currently have on you, and that's your smartphone. And last year there were more smartphones sold in the entire world than any other type of cellular service. And there are now applications that can be downloaded on smartphones so patients can get a visit from their physician, or not their physician, but from a physician through a lot of these outside resources for a visit. So there's a lot of challenges coming down the pike Patients are busier. We have a younger population that wants to get access earlier, and so there's going to be a lot of modalities that are going to be at their access. That's one of the reasons why I think you're beginning to see where reimbursement is now no longer the challenge that it once was, but we still have some issues that we need to work out. A little history. In the past, when I first started this program, telemedicine reimbursement was very limited. In some cases, just did not exist. So 8 or 9 years ago when we started, none of our third-party payers were paying. Medicaid wasn't paying. And if they did pay, it was very limited what they paid for. Medicare was just lagging and just beginning to talk about paying. So we were really challenged, how are we going to do this? There was a lot of grants out there that helped to support programs, but it was definitely a major challenge. Medicaid, like I said, did not reimburse. Medicare, the fourth bullet here where Medicare, it says reimburses for telehealth services. This still occurs. They will reimburse now only if the patient, the originating site, is in a health physician shortage area or metropolitan statistical area. So we only have 2 different areas within our healthcare system, one being in Newark, New York, the other one being in Batavia, New York, where this type of patient population lives. So outside of that, any of our other Medicare patients, we do not get reimbursed for. If our patients are residing in a skilled nursing facilities, which is one of the places where we provide consultative services, if they have an Advantage Medicare policy, it will cover it. But the caveat to that, it will only cover 1 visit per month. The 5th bullet there could be a little bit confusing, but what it basically is telling you that Medicare does cover for store and forward applications such as teleradiology and remote EKG applications, but they do not typically cover for direct interaction with patients, except for when I told you if patients reside in these specific areas. Medicare does cover store and forward applications such as teledermatology only in Alaska and Hawaii, and again, that's because of the remoteness in some of those in those 2 states. So limited reimbursement. Medicare continues to have limited reimbursement. We did speak to Dr. Sanders at great length yesterday because he's very much involved with the ATA and a lot of lobbying for changes in Medicare reimbursement. But as it still stands, Medicare has limited reimbursement to the way it is, like I just talked about in the last slide, except for healthcare systems that are applying for next generation ACOs. Medicare will cover consults for patients under this plan for home care only. So we're still limited. And I've already mentioned the 4th point here, if a patient, again, resides in a skilled nursing facility, we will get only 1 consult a month. And that is whether it's straight Medicare in the health physician shortage area or for those patients in an urban area that have an Advantage Medicare policy. These are some sites that are right now currently approved for telemedicine visits for Medicare. I think it pretty much speaks to itself. I don't really need to read them to you, but one of the things that I wanted to bring to note as far as the distance site practitioners, in a lot of instances we've been challenged to have psychiatric consultative services, and they will not cover somebody that's a clinical social worker that may be doing psychiatric consults and at a regular face-to-face visit. They will only cover a mid-level provider that's licensed, and that would be a nurse practitioner for those type of consultative services. The American Telemedicine Association, as I said before, they've outlined that there's very severe current restrictions as far as ACOs are concerned, and the ATA continues to spend a lot of time lobbying, speaking to both our senators, representatives, and whatnot about these limitations. And the feeling is that, within the next year or so, but we've heard this for quite some time now, that this is going to be changed. And one of the reasons, again, is they're saying to the legislative body, okay, you've asked us to take care of these patients. We're responsible for them from birth to death. Everybody's supposed to be assigned to some physician, but yet they have limited access, some patients do, to care. So how do you expect us to deliver this care when we have this technology available? ATA is also part of a 21 national associations and businesses that have sent letters of support to expand interstate access to care by Medicare beneficiaries. There's obviously, we know that right now if a physician is going to be doing telemedicine consults, they have to be licensed and credentialed in that state. There's a lot of lobbying going on right now that we could have interstate licensing, so that does not have to happen. But currently, anybody that is providing a consult has to be licensed and, more importantly, credentialed to be able to do that in that state. And also not just credentialed within the healthcare system, but also credentialed with the insurers. You guys want to jump in with anything? Any comments? Okay. New York State, this is the exciting part about it. New York State passed a parity bill on December 29th, 2015. Our Governor Cuomo signed a bill. We are the 22nd state in the union to pass this parity bill. We are now up to 29 states. I think the latest state was Connecticut. And basically what this bill is saying is all insurers, all third-party payers are required to cover all telemedicine visits. And this includes all Medicaid coverage as well. The other caveat to this, it also includes covering all home care visits. So any patients that are going home on home care monitoring will be covered as of January 1st, 2016. One of the things that was discussed yesterday with Dr. Sanders is, there's a lot of confusion around what's telemedicine, what's telehealth. In his opinion, I'm sorry, I forgot to tell you to advance the slides, Caitlin. I hope you're keeping up with me. Caitlin?
Yeah.
I apologize. I'm controlling my slides here thinking you're keeping up with me. I'm actually on the slide that says telemedicine.
Yep, we're right on there. Thanks.
Okay. One of the things that Dr. Sanders said yesterday is he wished that we never called it telemedicine, telehealth, virtual health. He said because it just confuses people, because really at the end of the day what we're doing is medicine. And he said in the past when there was no video capabilities, which we ended up coining the word telemedicine, if a physician called you up on the phone and gave you any type of advice, we didn't call that telemedicine when in fact that's what it was. So he said we just need to think about it as more, we're just expanding medical care, medical coverage, and if anything else, it's really connected medicine. But for the sake of this, for this particular webinar, telemedicine is defined as a real-time two-way audio-video communication, which also includes both video conferencing and store and forward. Next slide, please. Telehealth is delivering healthcare services using the telephone, remote patient monitoring devices, or other electronic means. The purpose of this is to facilitate the assessment, diagnosis, consultation, treatment, education, care, management, and self-management of patients' health care. So education is a really big component of being able to deliver this type of care through technology. Here in our healthcare system, we do offer diabetic education with our educators that are located on our urban campus to our rural clinics. So whether it's education in whatever capacity, it is a service that is covered. Next slide, please. So billing codes. This is the stuff that gets, I've always had to wrap my head around because I'm not a biller. So, but just to let you know, your typical E&M billing codes are the ones that you use. And the only caveat to that is you add a GT modifier to each one of these codes. And what that GT modifier says to the biller that's looking at it and the insurer rather, is this was a telemedicine encounter. When we first started billing, probably about 3 or 4 years ago, we went and we asked permission from our local third-party payers if they would pay for consults. I later learned from somebody from the ATA that to stop asking permission and just to go read the bylaws from your insurer, and if they don't say anything in there where they restrict telemedicine billing, then just go ahead and bill and put the GT modifier in it. Obviously, as of January 1st, we don't have to worry about that anymore, but for any of you people that are currently looking to bill, that's something that you could consider between now and January.
Just to note that the codes that she has listed on the screen are the most commonly used ones. There are several others at this time that can be used for like diabetes training and things like that also.
Next slide, please. I'd like to talk a little bit about credentialing because that was a huge stumbling block when we started to do telemedicine, because when you're asking a provider if they will please be a provider to do consultative services at another remote site, at a hospital or whatever, they have to become credentialed. And if they're going to be a provider at a private doctor's office, then they don't have to be credentialed. But if they're going to go to some Article 23 site, Article 28, they have to be credentialed. And so the state, in all their infinite wisdom, thank God, on August 24th, 2012, passed a bill, another one signed by Governor Cuomo, that simplified this process. And basically what this means is that the remote site where the telemedicine consult is going to occur, they accept all the paperwork, verification, and whatnot that has been done by the original site, the hub, and the physician does not have to go through this arduous credentialing packet. And the only caveat to that is obviously they have to sign a statement that says that they're only going to be providing services for for what they are qualified to do. So if you're a dermatologist, you're only going to do dermatology, and if you're a rheumatologist, you're only going to do rheumatology. So we have been using that because we have two rural sites. Even though these hospitals are part of our healthcare system, they still have their own their own entity, and so we have to get credentialed by them. And so we now have what we call a service level agreement, which, if anybody wants a copy of what our service level agreement looks like, I can send you a template that was drawn up by our legal department, that the hospital that we're going to be providing the consults to, the spoke, signs the agreement, and once that agreement is signed, then they accept all the credentialing, verification, paperwork, etc., that is in our original site's medical staff office, which once that bill was passed, I ended up getting a lot more providers that were very much willing to participate, because the two major barriers when we first started doing this was, will I get paid? And no, I don't want to go through all that to get credentialed. So now, fortunately, the state has now gotten rid of those barriers. Next slide, please. This is I know this is kind of short and concise, but this is bringing me to the end of our discussion as far as what I have to say to everybody here. I'd like to open this up to questions and answers, because we're here to, hopefully I have the right people in the room to be able to answer your questions, or we can direct you to wherever we think we can direct you to get the answers that you would like to your questions.
Well, thank you so much. We have a couple of questions. The first one is they just want to know if the skilled nursing facility is in a non-MSA in order for the reimbursement, when you were talking about that in the first couple of slides.
If it's for straight Medicare, they do. They have to be in an MSA. If the patient in the skilled nursing facility has an Advantage Medicare policy, it's reimbursed.
Okay, thank you.
And the caveat to that also I'd like to add is our healthcare system, we have five skilled nursing facilities. And so even though in some instances our patients right now we're not being reimbursed for it because they might be a straight Medicare patient, one thing to think about, going back to that first slide, what is a real return on investment there? Do we really want to make that patient have to leave the nursing home to go see the specialist and cost, and in the case of, for a lot of nursing homes, it ends up costing the patient the money for the transport. It doesn't cost the nursing home. And so we recently learned that every time a patient's transferred out of a nursing home, locally here, it's costing the patient $180 for transportation. So that's putting a financial burden on the patient. So we need to think about quality. We also need to think about service.
Great, thank you. The next question that we have, regarding credentialing of providers, is this practice acceptable by the Joint Commission as well?
Absolutely. Hands down. We got their seal of approval on it. No ifs, ands, or buts. They approved it.
Wonderful.
You're covered.
Yes. Our next is a clarification. They would like clarification that the providers do not I would like clarification that the providers do not need to be credentialed. For example, we are a CAH and may request telemedicine services from an out-of-area hospital. Are you confident that credentialing will be required?
I guess I need a little bit of clarification. What's an ACAH?
A CAH, which is a
critical access hospital. So
yes.
From a critical access hospital to a regular hospital?
Yes.
My understanding is any time you went from one hospital site to another, you had to be credentialed.
Okay, thank you.
The only time I understood that you did not have to be credentialed is if a physician was providing a consult to a patient that was in a private physician's office.
Okay. We have let's see, where's the next question? Is the originating facility fee reimbursable under Medicare, PPF, or FQHC billing?
We're looking that up. We're going to give you that answer in just a second. So you're asking me if the originating fee, meaning the technical fee?
I believe so.
My understanding is that the technical fee is reimbursable for Medicare as long as you're in the right site of service.
It doesn't clarify the guidance.
But
it doesn't clarify in the guidance if FQHC would be different, but it is reimbursable. So it doesn't clarify if FQHC would be different. I would think not.
Thank you.
She said she would think, Diana's saying she would think not. So that would be one of the questions that I would ask. You know, if you have any legal people or whatever, they can investigate that, you know, I would consider doing that.
Okay, our next question is, we have a few people that would like a copy of the service level agreement template. If you can send that to me, I can get that out to the people that are looking for it.
Yep.
And our next question is, what sites does the patient have to be located at? For example, 28 or 31 private practice, etc., or 31 to 3128 to private?
Again, our particular environment, most of our specialists are coming from an Article 28 site, but not in every situation. I don't know if there's restrictions on where they need to come from or where they need to go to. I think the most important part about that is where you're providing the consult to. If it is in a site that's in Article 28, 20 to 31 or whatever, Diane, can you speak to that?
Not Article 31, no, I cannot. Article 28 would be an originating site, but Article 31, well, there's a community mental health center, it doesn't list that though. That we're unsure of at this point.
All right, thank you. For the people that are asking, we will be providing a copy of the presentation afterwards. I will send that out as well as with the template that people are asking about.
Can you do me a favor, Caitlin, and send us the question that they asked, and we'll see if we can't get the answer, and then we'll give it back to you, and you can give it to the participants.
Sure, no problem.
And the other thing is, one thing I'd like to add at the end, because there's always been confusion around this, when we first started doing telemedicine, we automatically had put into part of our workflow that patients would sign a consent form to have a telemedicine consult. We just did this because we felt it was important for patients to know that a lot of people think when video is being done, it's going to be sold on YouTube and that kind of stuff. So just informing our patients that it's an informed consent. Everything's being done over HIPAA-secured environment, and so there's no risk of that. There is no legislative, there's nothing in legislation for the state of New York that mandates that a consent has to be signed to date. There are other states out there that mandates it. Our state does not. I have to believe, because we're such a regulated state, that at some point in time that may occur. We continue to get consent forms, but that's up to the discretion of each program.
Okay, thank you. Let's see. I believe that has all of our questions. We do have a comment Someone sent in, it says the Medicare beneficiary resides in or utilizes the telemedicine system in a federally designated rural health professional shortage area, county that is not included in an MSA, or from an entity that participates in a federal telemedicine demonstration project that has been approved by or receives funding from the Secretary of Health and Human Services as of December 31st, 2000. I don't know if that clarifies it for anybody else. Did I believe, is there any more questions? We have one other question that pops up. They want to know the challenges that you've had for corporate compliance.
I would say that the biggest challenge is just confirming which payers pay and which ones don't. But as Cindy mentioned, that what we do is we do bill for all of the services that we provide, with making sure that they're accurately billed for, meaning putting the GT modifier on them so that they are aware. We also make sure that all of the evaluation and management guidelines for those major codes are met. Obviously, doing it over the TV or the telehealth services makes it a little bit more challenging, but with the right equipment, you should be able to meet the requirements for those levels of service that you select. So that was pretty much the biggest challenge, was making sure that we were meeting all of the requirements of the CPT codes by using the equipment that we had available to us.
So what she's talking about is when you start to build a higher level, because we do have a tele-ICU application. Then there has to be so many systems covered in order to be able to put out the higher level bill. And so that was a challenge. I mean, we needed to make sure that we had a stethoscope and other peripheral equipment so that the specialist could cover those diagnostic exams to be able to bill appropriately.
Okay, thank you. They want to know who stores the Telemedicine Encounter.
We don't video we don't store the encounter. We don't keep tapes of encounters. Once they're done, they're done. And
thank you.
Are you talking about documentation? Are you talking about the electronic health record? Are they talking about the actual video encounter?
I believe they're just talking about the video encounter.
Because there can be, and obviously as we move forward and everybody's becoming a very electronically health record environment, we're still doing consults with patients that are not connected to our Epic system, and those things obviously create challenges. We've gotten very fancy. We've gotten very creative, and we do a lot of faxing and that kind of stuff back and forth when we've had to. Some of our doctors can sign in onto other people's EHRs, but it does create a challenge when you're trying to do that. Get the right medical.
Oops, sorry. Go ahead.
It is a challenge when you're trying to create the right medical information, so that physicians can obviously have the information in front of them to make the right diagnosis. Especially challenges are for like our rheumatologist, and endocrinologist, and nephrologist. They rely heavily on lab data. So that was always a challenge, making sure if they couldn't get into our medical record, making sure that they had a copy of the lab being sent from the patient's site.
Thank you. Following up on that, do you have a list of EMR vendors who have that capability?
Right now, I just learned this yesterday from Dr. Sanders, both Epic and Cerner, they're all going to be able to interface at some point in time so that you can push the electronic medical record that you create to them, but you can't pull anything out of a medical record. So it's still very limited. The EMR companies really need to work, obviously, a little bit better with these types of applications or all types of applications. So we're really not there yet.
Do you know if MedEnt does it?
I mean, as far as interface, well, you can, in a lot of situations, you can get access, like a provider can get access into a MedEnt account, but they're not. But transferring like your information into it, you can't do that. You can go in there and view the labs and that kind of stuff, but you're not going to be able to get your your consultative note in there. Sometimes it has to be scanned and sent to somebody, and then they have to put it in. So you have to work with each different EMR company to find out what you can and cannot do. Nothing's ubiquitous yet.
Of course not. That would make things way too easy. We have a question that is unrelated to billing. They want to know if you've had any trouble with provider pushback.
Oh, God, yes.
And how those have been addressed. And any challenges with provider, including physician and training.
Okay, so provider pushback. That's probably the number one challenge I've had to deal with over the last 9 years. I'm very fortunate because I've had some very good champions in different areas. But I can tell you, and you can share this with providers that you're currently interfacing with, telemedicine is no longer an option in your world. And I'm going to tell you why. The train is no longer coming down the track. It's about to run over you. And the reason why I tell you that is there's a lot of for-profit companies out there that are going to be providing services to patient populations, whether or not your doctors decide to get involved. I'm going to give you a couple examples. Walgreens, Rite Aid, CVS, even our local Wegmans are all putting kiosks in their stores so that you can go in there and have a primary care visit, and it's going to expand out to other type of specialists for $49, and you're going to get a board-certified doctor within 1 or 2 minutes that's going to talk to you about what's wrong with you today, and they will have access to an otoscope, a stethoscope, etc., a thumoscope. So it's going to be a totally interactive, private encounter. So either we start participating or other people do your business for you. That is not, I'm going to challenge people on the call to go to different websites. Go to Teledoc, go to Specialists on Call, go to American Well. That's just to name a few. And they're in the retail space. So it's not a matter of whether or not you want to participate. It's a matter of you better participate because your patients will begin to leak away from you. So, provider resistance, of course I've had provider resistance. How do you get around it? You find the champions, you work with the champions, but you also tell the people that are still reluctant, okay, if you don't want to participate, but this is what's happening out there. So maybe you want to think about it.
I like that approach. That must definitely get their attention for that one.
Gotten a lot of people's attention, especially here in our healthcare system.
I can imagine.
Any Wegman, I don't know if you know the Wegman chain, but if they're in the space, you know that it's profitable.
Yes. I know I had just read about CVS and Walgreens doing it. I hadn't heard about Wegmans doing it yet. We have one last question. As a critical access hospital, do we have to credential physicians that consult for us from another non-critical access hospital?
I would think the same thing. I would say, Diana, wouldn't you say yes? Yeah. I would say yes. I think when you're doing from one, entity like that to another entity, credentialing is a must. The only time where I've seen it's not mandated is if it's in a private space, because then you're not under the governance of the federal and state government. Okay. And JACO and everybody else.
Have you seen when it comes to credentialing, if you have the two hospitals that want, you've got one hospital that's got a provider willing to do the telemedicine encounter. Have you seen it where they've just been able to write up a contract and say, because you're credentialed with that hospital, that's good enough for us, and then they don't have to do that next step for credentialing?
That's what the service level agreement's all about.
Okay. That's what I thought. I just wanted to clarify that.
Service level agreement basically says that the spoke hospital, which is, the hospital you're doing the consult to, agrees they will accept all the paperwork, all the verification, everything that the medical staff office has done in the hub hospital. So now you've made a contractual agreement that, they agree that they're going to rely on all that verification that medical staff office has done. So what the spoke hospital has to remember is they're still responsible for keeping track of the specialists that are providing consults in their facility when they're going to, when they need to be recredentialed. They've got to keep their eye on that. The originating hospital is not going to do that. So they got to make sure that they're keeping up to date with when somebody needs to be re-credentialed every 2 years or whatever it is.
There's a comment that says, I believe in critical access hospitals and FQHCs, the credentialing and privacy rules may be different. Should double check on that.
Perfect. I mean, and that's what we would say to you, because I don't have enough experience in that to say that I know the right answer to that.
We would just like to remind everyone, Cindy's going to send a copy of that service level agreement to Caitlin. That, along with a copy of the PowerPoint slides and a recording of today's webinar, will be made available at a future date, probably the beginning of next week. And email will go out to everybody who registered for the webinar with a copy of that agreement. And at the moment, Cindy, there's no additional questions if you wanted to do your last slide.
Well, my last slide is just a quote for people to read and think about.
All right.
So we're making a trail.
If there's no further questions, we would like to thank Cindy and Diane very much for their time, taking that moment out of their busy day to be with us. We'd like to thank all of the attendees for the great questions and for participating in today's webinar. We hope you have a wonderful rest of the week and a great weekend. Thank you and take care.